Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hi, this is Kelly Ramsey. I'm an addiction medicine and internal medicine specialist, and I'm here with a colleague, Dr. David Gorey, who is an OBGYN, and he's going to talk to us about best practices for pregnant people and postpartum people who use substances and may or may not have hepatitis C. So hi, Dave. Welcome to the podcast today. Can you tell us a little bit about yourself?
Sure. Thank you, Kelly. I appreciate it. First, I'm an OBGYN specializing in maternal fetal medicine. I have a practice of high-risk patients with various problems, and then a separate subgroup of patients that are suffering from substance use disorders and mental health disorders. And I'm working currently at Stony Brook University Hospital, which is an academic medical center serving Suffolk County in Eastern Long Island. Just a little bit about our practice. Our own group does about 2,500 deliveries a year, and the hospital does almost 4,000 deliveries annually. And when you look at what is our sort of setting, for those who don't know Eastern Long Island, it's a suburban and rural setting. There are parts of Suffolk County that are very rural and parts that you can very much consider suburban. So it just gives you a little bit of background of where I'm at and what I do.
And how did you get interested in treating pregnant and postpartum persons with substance use disorder and mental health diagnoses?
So that happened in 2015, 2016. I returned to Stony Brook. I wasn't working here before that. I was many years ago working here, but I returned again. And the problem that was going on in Suffolk County, we were seeing patients appearing in labor and delivery withdrawing from opioid use or other substances. And we realized that there was no place for them to really seek care because they were pregnant. Many of the centers did not want to see pregnant patients. So we educated ourselves. We have a group of about 8 providers of different types of nurse practitioners, psych NP, maternal fetal medicine. And we began seeing patients with substance use disorders and mental health disorders in order to provide service to these patients and allow them to have prenatal care and have a safe and happy delivery, as well as their newborn being taken care of in the appropriate manner, and for them to be able to seek care without any judgment or any kind of, we'll say, stigma placed upon them.
And how do you feel like that impacted your practice personally?
I'll say it first, my knowledge beginning before that was, I'll say, somewhat limited. And now I don't consider myself a true expert in substance use disorder, but when it comes to substance use disorder and pregnancy, that I'll put myself as an expert. And it's helped me to grow and to see the different sides, to understand the patient perspective, what happens with these patients, the various challenges that they face. When you look at patients such as that, they are very fearful of the child protective services. They're fearful of the laws that surround things. And they're also afraid of how they're being judged when they're being seen by various providers. So it's trying to remove that judgment, trying to make them feel that they're another patient in our practice, and there's no difference between what we do for them and what we do for any other patient. That has really helped me grow as a provider taking care of patients in pregnancy.
And you put it beautifully. I think that is what happens a lot of the time, is that people aren't given space to have their stories heard. And so people don't have empathy or understanding, and instead just sort of have a stereotypical view of what a person who uses drugs is like. And so I think you're right. I think finding that space in your practice, educating yourself and having your staff educate themselves certainly can create a lovely and safe space for people to get their care in. So thank you for that in your practice. I'm going to transition us into really focusing on hepatitis C best practices with pregnant and postpartum persons. So first question for you is, with respect to screening and identifying hepatitis C in pregnancy, How challenging was it for you and your team to implement universal screening for hepatitis C in pregnancy?
So skip back about 5, 6 years before from today, and we were screening patients based on risk factors at that time. So patients who had substance use disorder, IV drug use, partners with IV drug use, et cetera, we were screening them, and we didn't really have a universal approach. Then we changed over completely to universal screening. So all patients as part of their prenatal care labs, so their first prenatal care labs, have a hepatitis C antibody obtained with a reflex viral load. And I'll just say, why did we switch over to that? And that's based on the fact that our group got together and said, well, diseases that are curable, why wouldn't you want to identify it? And in that was sort of the reason why we attacked this and made it a universal screening in our practices. Basically, that you can cure hepatitis C. If you don't know you have it, that's a problem. But if you know you have it, we can direct you to the right place and you can seek care and be cured.
The other thing I think, and you addressed this in the prior question, was that people may not feel comfortable being forthcoming about their substance use or identifying to another person potential risks that they might have. So there's an inherent fault based on both fear and based on implicit bias from the provider side about who is appropriate in risk-based screening. So really, universal screening is the gold standard because, as you said, we don't know who has what, and the only way that we know is by screening everybody. So it's great that you guys implemented that in your practice long before the law required people, or the Department of Health directive required people to do universal screening in pregnant persons. So my next question is, what are your best practices for linking pregnant and postpartum persons to care or treatment for hepatitis C management?
What we do here is we are linking these patients that come back hepatitis C positive with a viral load to gastroenterology team, as well as infectious disease. So we're getting those patients appointments. We have a mechanism in our EMR to message the correct people, and then those patients can easily obtain or they get contacted to obtain an appointment. Additionally, the newborns of these patients will be followed. The babies will be followed by pediatric infectious disease. So that's sort of an automatic on the discharge of the baby. So that's how it's set up here. I will say, before you ask me the question, what's the challenges there? Sometimes the challenge of follow-up and getting them to that appointment can be difficult. I mean, all patients, those who are motivated, will make the appointment and get there and try. And those who are less motivated maybe need some follow-up contact, et cetera, to get them to the appointment and see the appropriate providers to obtain a cure.
And how do you, in your practice, close the loop on that referral to make sure that people do get to the appointments that you've set up for them, make sure they do get the assessment and treatment that they need?
So closing that loop was easy because we had somebody directly identified as the person who closes the loop. However, she retired. So in our current state, and being honest, we are trying to figure out a best practice for getting that loop closed. In other words, who can we identify that will make sure they contact all these patients and at least advise them to seek the care that's set up for them already.
And I think this is a good time to just remind providers that when they initiate a referral from a liability malpractice perspective, the burden of that referral completion lies with the referring provider. So it is imperative that systems have a means to close that loop. So whether that's creating something in the EMR or having a person dedicated to this, et cetera, or hiring a Hep C navigator, for instance, a variety of ways to do that, but agree that that is an important piece in the puzzle. And what are the best practices in your practice for screening for substance use in pregnancy? Do you do universal screening?
So we do universal screening in our practice. We happen to use Audit C and PHQ2 and also Q9 at our first prenatal care visit. We also use the Edinburgh Postpartum Depression Screening, or EPDS, looking at mental health, et cetera. So those are all in place in our practice. The hospital itself, when you're admitted to labor and delivery, they use Audit C and DAST, D-A-S-T, another screening tool. Again, looking to identify patients with substance use, alcohol use, and or mental health problems. There are a host of tools available. Mantra has always been pick a tool, use the tool. The yes/no question doesn't work. So, and I think that that's been proven over and over again.
And I think that's a key point that you made. All the tools that you mentioned are all validated tools for assessing for substance use, or in the case of the PHQ-2 or PHQ-9 or the postpartum depression survey, those are specifically for depression. But these are all validated surveys. These are not arbitrary, random questions that people are asking about substance use. So again, the standard of care is using a validated tool. Once you identify substance use or substance use disorder in your pregnant patients, how do you or your team support them throughout their pregnancy?
So first, I'll go back to what we mentioned before, listening to their story. I ask every single patient, tell me your story. Why are you here? And they typically give me the short version, of which I say, no, back to the beginning. How did you end up with using the substance, whatever it is? Majority happens to be opioids. And how did that happen? And tell me a little bit about it. And I also put in my statement there, and there's no judgment here. I just want to understand you. I think that helps the patients to at least understand that I am actually interested in what is going on with them. And so you have a better connection. Then as far as our practice goes, so we're fortunate because we designed a team to take care of these patients. So as I said before, we have 4 maternal fetal medicine physicians who can provide management of opioid use disorder and buprenorphine. We have a nurse practitioner and a psych nurse practitioner, as well as social workers in our office. Our office manager is involved in this in order to follow patients and make sure that they're able to get appointments easily. And we also work very hard at breaking down barriers to access. So if someone is referring somebody or a patient contacts us in any way that has substance use disorder, they are streamlined to see one of us in a very short amount of time. It could be the same day or within about 2 or 3 days. And we did that because we realized that in order to provide good care for these patients, when they have the idea that they want to seek help, the help has to be there. And you don't want to put them off 2 weeks or 3 weeks because you don't have a place to see them or a room in your schedule. So that's why we broke down those barriers to allow for access.
That's fantastic. You also have quite a wide range of team members on your multidisciplinary team, which obviously we know supports complex care so much better than a single provider with a single patient. So you started to mention buprenorphine, so that transitions us into our next set of questions. So when you are educating patients who are pregnant with opioid use disorder about medication for opioid use disorder or MOUD, what do you talk about?
So I'll start with the choices of medications, whether it's methadone and or buprenorphine. We have patients on both, and occasionally we'll have someone who's on naloxone, but that's
naltrexone.
It is a lot more infrequent. The use of either of those medications, because they want to know, is it safe? And actually, our own data here, because we just recently reviewed it at our institution, and we have almost 500 patients over the last 5 to 6 years that we've cared for and followed their babies. And those babies in patients who are on buprenorphine or methadone, their long-term outcomes as far as developmentally, both cognitively and motor-wise, are normal. So giving first that information to patients that these medications are not, 1, teratogenic or causing problems with structural development, and 2, long-term wise, that they are safe. The next thing I like to let them know is the reason why you're on either of these medications is to keep you, I say to the patients, from drifting to unhealthy behavior. And what is unhealthy behavior is returning to use of a substance like fentanyl or street heroin or street oxy. And as we all know, in 2024, the presence of fentanyl in various street drugs has led to overdose and death in numerous people across the country. And pregnant patients are no different in that with respect to that. So the goal for MOUD is to keep them in a healthy place and not to drift off to using other things.
And you mentioned a couple of really important points. Not only are pregnant and postpartum persons immune from overdose, they're actually at increased risk for overdose, particularly in the third trimester and postpartum, which probably a lot of pregnant and postpartum persons don't know that they're at increased risk. But we know that despite it being a potentially beautiful event of having a baby, it can be extraordinarily stressful, particularly for individuals who don't have a lot of social support around them. So it can actually be a stressor. So how do you counsel patients about overdose risk, and what do you do besides putting them on methadone or buprenorphine to decrease their overdose risk?
So exactly what you just said is speaking to them directly about what are the risks of use of street drugs or heroin, oxy, fentanyl, et cetera, and reminding them that they probably know someone who has overdosed. So that sort of brings it home in a personal way for each of the patients. But we are very keen to making sure that patients have the availability of Narcan. Narcan prescriptions are given to every patient during prenatal care. They're given to patients on discharge from the hospital who have any history of substance use. Additionally, we know now that patients can go to any pharmacy in the state of New York, actually, I think in the country, but at least the state of New York, and can walk in and get Narcan. So it is available relatively easily. And there are some places that will give out Narcan kits as part of their care at various facilities throughout the state. So we tried to make sure that that is in the forefront, so they have this present, and they have it present either for themselves or for a family member or a friend, that anyone who may be there, and that they understand how to use it. And if anybody is with them, we make sure that they also understand how to use it. And I will say one of my questions to patients when they are seeing me is, how many times have you received Narcan? It helps me to understand how significant their substance use disorder may be. And also helps me to understand that they know what the medication is. So that's all sort of what we do during prenatal care.
The other thing that I got as a common question when I would do naloxone trainings is it okay to use naloxone in a pregnant person? So I'm sure you get asked that question. So what is your response when you hear that question?
Answer to that is, it is perfectly safe as far as pregnancy goes. We have not found any problems with it. Number two, typically you're using it in a situation where the alternative may be death. So I don't know that I would be so worried about any kind of effects to a fetus if the alternative is dismal. But when you talk about like combination products, say the buprenorphine naloxone, that product has been shown very clearly now that have no real lasting effects and no teratogenicity with respect to the newborn and the fetus and the newborn.
Great, thanks. And also, just for our audience, in case they are not aware, in that buprenorphine naloxone combination product, the way that the formulation is taken, which is sublingually or under the tongue, there is really no bioavailability of the naloxone. So again, the individual, the pregnant person, and the fetus are really not getting exposed to naloxone in that situation. So I'm going to move us into my next set of questions, which are about barriers that you see to implementing these best practices in your setting. So you alluded to this earlier, but how do you think stigma plays a role there?
Stigma plays a very large role, because the patients come back and tell me their experiences that they have in our labor and delivery unit and or with other people that they've seen in prenatal care. And we have been working very diligently to try and reduce stigma in our practice. It's one of the things that I will say, no matter how you look at it in medicine, if something personal is mentioned to you and you don't like it, you're likely not to seek care or take care of yourself. So it is important to understand that as a healthcare provider, that if I happen to have not so much hair, so if you tell me, if I hear someone in the background say the bald guy in the waiting room is ready, I might not come back to that practice the next time. So it is important to remember and these patients are very attuned to feeling that they are less of a normal human, that they're less than that because of their substance use. So we've been trying to educate our staff. So the front desk, the medical assistants, the nurses, everybody in our office to understand why we do what we do, how we can curb our language that we use, how we can make sure that patients feel that they're no different than any other patient. And it seems to work. Little things we do is when we schedule a patient for an ultrasound, I have to write something as an indication in the computer, and then it gets printed and the patients see it. So instead of putting substance use disorder or addiction or language that we shouldn't use, we use what our program is called, which is MOMS, MOMS. So we just simply put an acronym there. The front desk knows exactly what it is, and nobody needs to mention anything that would make a patient feel less. So that's just one example of trying to change language so patients don't feel different.
Do you think that in implementing best practices, again, in your setting, does provider lack of awareness, and that could be lack of awareness about substance use disorder, it could be lack of awareness about hepatitis C, but do you see that provider knowledge base may be a barrier sometimes?
It's absolutely a barrier. Many providers don't even recognize how they say things or what they say. And I think you have to do a little listening to yourself and what are you saying? Now, I don't know why some providers feel that way. Are they afraid of this because maybe they have a knowledge gap and they don't know how to manage it? Is that why they have use the language they use? I hope that it is ignorance that is driving it and not something else, when providers don't understand stigma and how they speak to patients. But as I said before, trying to reduce it improves the patient compliance, helps patients to have better care, whether you're talking about substance use, hypertension, diabetes, whatever disorder you want to talk about.
The way that I always think about it is treat your patients as you would want the people you love best in your life to be treated. And if you feel okay with the way that you're interacting with your patient, then that would be okay with your loved one, then you're probably doing all right. But if you question it, then clearly maybe you need to rethink how you approach your patients. And you mentioned how you, in your ultrasound order, would maybe say something differently. So again, the patient reading it would not feel stigma. Are there any issues that you see that come up within your electronic medical record and around documentation there? Are there ways to address that as well?
So recently there was a small little manuscript that was published that talked about the language in the EMR and substance use disorder, et cetera. And that article sort of enlightened me a bit to thinking about, well, I know what I write in the EMR, but what do other people write? And should we be addressing this in some way? And that has sort of become a focus of part of the stigma I'll say, was unseen stigma. But now in 2024, the patients see everything you write. They see the labs. They tell me their own blood pressure before I walk in the room. They know it on their little phone. So everything is transparent. And so you as the provider need to really think about, what am I writing? I've recently been actually looking at, should I write opioid use disorder or should I write opioid dependence? And I'm going back and forth with what I write in the medical record, because I think opioid dependence is for most of the patients I care for who are on MOUD, that's what it is. It's not misuse. They're using what they're supposed to be doing. They're using the medication as prescribed.
You have some really good points there. I think that as healthcare professionals, we always need to think about, is what I'm writing in the chart professional? Is it unbiased? Is it using appropriate non-stigmatizing language? And is it objective? And if, again, you meet all those criteria, then your charting is probably in a good light. But if you are not meeting those criteria, then you have to rethink how you're charting. So lastly, I'm going to talk about how did you operationalize best practices. So we're going to get into a little bit more of the nitty gritty here. So regarding the best practices that we've talked about that you operationalized in your practice, let's talk about how you did it. So did you do any specific changes to your EMR? I know some practices have the ability to do that and other practices don't because they're in too big of a system that they can't make changes. But was that something you were able to do in your practice? Could you do EMR prompts, or EMR algorithms?
So what we actually did was we have a set order panel for first prenatal visit. And in those prenatal labs, that's what it's called, obstetric prenatal labs. That's the title. We simply added Hep C with reflex testing for viral load. That was the order. And we turned it on. So when we obtain our other prenatal labs, this is also automatically there. Then when patients come for delivery, because although we at Stony Brook, as I said, our group has some of the patients that deliver at Stony Brook, but not all of the patients. Other practices also deliver here. So we added on admission for when you come in for admission for delivery at Stony Brook, we turned on the hepatitis C screen. So the same thing, it's a hepatitis C antibody with reflex viral load testing that's automatically checked off already. So when you get admitted, New York State requires now the hepatitis C testing, and it requires syphilis testing on admission for delivery. And we also added HIV on admission for delivery. And all of these things are curable, and all of these things also matter to the pediatricians taking care of the baby. So for those reasons, that's why we have all of this turned on in order to, in the EMR, in order to best provide care for our patients.
And did you create specific educational materials for patients around Hep C and pregnancy?
So we have some Hep C placed in our prenatal care packets, but we are still working on how are we going to get this information to patients that are not in our practice, that are in the hospital. And so we're working on that, and we're always looking for information. So anybody who can send us more information, I'm happy to receive it and incorporate it into our education.
And did you provide education to providers?
We have spoke about this several times at our own faculty meetings, but coming up in the very near future, we have a grand rounds in our own hospital system here about hepatitis C testing and why it is important and how to do it. Along with that, there is some mechanisms that are, or we'll say treatment modalities that are available, that may be available this fall for patients who are pregnant, so they can be treated during pregnancy. And that is upcoming this fall. So we wanted to make sure that everyone in our department knows what's going on and that they understand the new laws in New York surrounding hepatitis C.
So just to be clear for our listeners, so hepatitis C, currently there are not any approved medications for using to treat pregnant persons during pregnancy. However, it is always a decision that is a shared decision clinically between the provider and their patient. And there are active ongoing clinical trials in pregnant persons using hepatitis C medication during pregnancy. So hopefully we will have those study results soon, and hopefully we will have an indication, FDA approved, that you can use Hep C medications during pregnancy. You mentioned again a lot of folks that you have on your multidisciplinary team. Have you hired any specific staff that's either peers or peer navigators for substance use disorder, or Hep C, or specific Hep C navigators? You have Hep C champions in your clinic, anything like that?
So I'll say thank you for bringing that up. Actually, that is on our list of hires that we are anticipating. I actually have identified someone that currently works with us that wants that position. And that is to be a navigator for everything you just said, substance use, hepatitis C. So that's in the works here. Currently, we don't have anybody, but our office manager assumes some of that responsibility that helps with the navigation of these patients. So it is soon to be changed in our own practice. Difficult, when you think about obstetric practices across the state of New York, depending on the size of your practice and location, these things are not easy to have available. Many practices are not going to have a social worker, have various nurse practitioners. So understanding, I guess, the resources and setting up an easy referral system to, say, gastroenterology and or infectious disease, that you can transition these patients to care there and have someone in your office follow up so that you make sure these patients get to the right spot after they deliver. It is not easy, and as I said, in certain parts. And then if you're in a system like I am, there's a little bit of ease, but it's not as, I like to think it was super easy, but it's not. Patients also can be difficult after they have their baby, and they have these difficulties because they're dealing with a newborn. They can't always go places. They don't have anyone to take care of their baby. So they have to bring their baby with their appointment. They have to, go here or go there. If they have to go to various programs for their substance use disorder and they have a newborn, they have to figure that out. So sometimes in the postpartum period, it's not so easy. And that's why they just need some reminders.
Yeah, for sure. And it's great that you're looking to expand your multidisciplinary team. I mean, we're all aware of the workforce issues. So I'm actually really impressed by the breadth of your multidisciplinary team that you already have. The other thing I want to mention again, just for our listeners' edification, is that, again, your workflow in your institution is to send folks to infectious disease or to gastroenterology, but treating hepatitis C is super easy, and there are lots of primary care providers who can do that treatment as well. So there are, for example, federally qualified health centers in the area of your facility that would be more than happy to welcome patients and treat them in the context of primary care. So just wanted to throw that out there. And I think my last question is, currently, even though you have a really well-rounded and robust program at your practice, do you currently see any gaps in your system in identifying and addressing hepatitis C and substance use in pregnancy? And if so, what are your plans to close those gaps?
I think first of all would be, as far as gaps go, are trying to minimize the provider knowledge gap with respect to hepatitis C, with respect to substance use disorders, and also with stigma surrounding both of those issues. That would be the first thing, and how to address that. We have been working very hard in the state of New York in various capacities at providing grand rounds, educational events to obstetricians, to family medicine, to anyone who's providing care, midwives, et cetera, who's providing prenatal care, to try and at least have them think about how they manage patients with these problems, substance use and hepatitis C. Secondly is access. So making sure that there is access to your practice. Although I've been trying very hard with this, it's still a problem, and I'm sure it's a problem for everyone. We're all busy. We all seem to not be able to add even one more patient, but you can. And making sure that the patients are seen in a timely manner, meaning you can't say, well, come on in 4 weeks from now or something like that. That's not going to work for most of these patients. And I think explaining hepatitis C and understanding hepatitis C is also important. So I get many, many questions. Patients have a hepatitis C antibody positive and a viral load that's negative. Well, they have hepatitis C, is what the provider that's asking the question. No, they have had hepatitis C. They don't have active disease. And that's one little hurdle that has to occur, and understanding that viral load matters, just like it does with other disorders that are virally transmitted. So I think that's the three major barriers that I have, and most of it's on education.
Great. Well, I want to thank you so much for taking the time to chat with me today about this important issue, but also just thank you for your compassionate care that you're providing for pregnant and postpartum persons at your facility. And it's always a pleasure to chat with you.
Oh, thank you. And I agree. It's always a pleasure to chat with you. And I always learn something whenever I speak to you. So
thank you so much for your time.
Thank you.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.